Thank you very much. It's a pleasure to be back here in Vicenza for this very prestigious meeting. Today I have been asked to talk about the impact of corporeal ultrafiltration in management of patients with fluid overload. I think it was actually a very great, I would say, setting in which we started with congestion, how bad it is, then we talked about diuretics, and we are finishing with the mechanical extraction of fluid. So when I was asked to talk about fluid overload, I thought I should focus on certain subset of patients because I thought it is too broad. I decided to talk about heart failure, acute heart failure, for three reasons. Reason number one is that congestion is the main reason why patients with heart failure come to the hospital, right? This is based on ADHERE registry. The next reason is that many of these patients, as you heard, present with diuretic resistance. There are different definitions for that, but I think most people agree that 1/3 to 1/4 of the patients present with diuretic resistance. The third reason is that ultrafiltration has been very well studied in this subset of patients. I'm not sure in other subsets it has been it has been studied so well. So I decided it might be a good idea to talk about heart failure as an example of how we can do mechanical fluid extraction for fluid overload. I'm not going through the details of why heart failure is important, but there are two things at least that we should realize. Heart failure is the main reason why patients come to the hospital after the age of 65. That's the primary reason for hospitalization. To put it in the context, less than 65 years of age, it would be pregnancy, the main reason. So this is how important it can be. Second is that it has a major financial burden on healthcare. As you might know, in the US, it will go over $50 billion in 2030. Okay, the question would be, as you actually heard from the other speakers so far, what is the main tool we are using for decongesting patients? This is based on ADHERE database, 150,000 patients. We see that IV diuretics, as we all know, are by far the most commonly used tool for decongesting these patients. But the question would be, how well are we decongesting them? How efficacious the diuretics are? And this is a very important question I had. This is how we are doing. On the x-axis is the change in weight as a surrogate for decongestion. On the y-axis, we have the percent of the patients. As you see, nearly 1/3 of the patients come to the hospital for fluid overload. They lose less than 5 pounds, 2.4 kilograms, and leave the hospital. So 1/3 of the patients lose less than 2.4 kilograms. And it's not the only problem. The problem is that 16% of the patients come to the hospital for fluid overload. They gain weight while we are treating them, and then they leave the hospital. So if you think about it, nearly half of the patients come to the hospital. They either do not lose much weight or even they gain weight and then they leave the hospital. So it would come to no surprise that heart failure has the highest readmission rate among all medical conditions. You remember that I said congestion, not organ hypoperfusion, is the main reason why patients with heart failure come to the hospital. Okay, so now I think we agree that we need to look for other options. This is how I look at the interaction between the kidney and the heart in the setting of acute heart failure. And as you see, I have put congestion here, not just as a presentation, but I think it's an active parameter that has mutual relationship with both the kidney and the heart. On the outer circle, you see there are two schools of thought for acute heart failure. One is the low forward flow, which is on the outer circle, and the other one is high backward pressure, which is a newer, actually, theory. Ultrafiltration will take care of this part, hopefully breaking this cycle. So the question would be, has it been shown to break these cycles? And as you see, this slide is not meant to be read, but it's just meant to mention that this has been something that we have been thinking about it for several years. Actually, the era of ultrafiltration for heart failure has two sides. One is before 2000. Most Italian studies were done actually at that time, Giancarlo Marenzi and his groups. And the other part is after 2000, where the dedicated ultrafiltration machines were put on the market. There were several benefits that were proposed, and I put proposed, not necessarily proven. There were several benefits that were proposed based on those studies. One of them, if I want to mention, is the higher mass clearance of sodium. What it means is that when you use diuretics, the amount of sodium in the urine would be somewhere between 60 and 80 millimole per liter. This is hypotonic urine. But when we use ultrafiltration, we are removing a fluid that is 140 millimole per liter of sodium. So we actually remove much more sodium than with diuretics, which, as you know, sodium is the main determinant of extracellular fluid. Well, if you want to take a look at the clinical trial, see based on these pathophysiologic pathways, how we are doing with ultrafiltration, I'm going to take a look at just a couple of them. The first study, which actually so far is the largest study that was completed, was Unload trial, was published in February 2007. They randomized patients to diuretics versus ultrafiltration, 100 patients in each arm. This study was sponsored by the manufacturer of the ultrafiltration device, I should say. This is what they found. At 48 hours, we can remove more fluid with ultrafiltration compared to diuretics. And the good news is that it doesn't come at the cost of worsening renal function. They looked at the worsening renal function at different time points, and they reported that at all times they were pretty much the same. You would think that the red is ultrafiltration. It shows a little bit more worsening renal function, but it seems that it has been statistically insignificant. What was the main finding of this study that was reported several times is here. You do one session of ultrafiltration, one session, and then you put the patient back on diuretics and the patient leaves the hospital. For the next 3 months, this patient is less likely to come to the hospital for congestion compared to diuretics. This was a main finding, and other secondary endpoints were also in favor of ultrafiltration, such as unscheduled office or emergency department visits. Then came Karis heart failure trial in November 2012. This is the only NIH-sponsored trial in this field. They could randomize patients to stepped pharmacological therapy versus ultrafiltration. And remember that these patients had to have some degree of renal dysfunction as opposed to Unload trial. These patients had cardiorenal syndrome. This is the main finding of the study. On the x-axis is the weight loss, again, as a surrogate for decongestion. As you see, ultrafiltration and pharmacologic therapy in this study actually had the same effect on fluid removal. What was different was the effect on the kidney function. Ultrafiltration was associated with more worsening renal function compared to diuretics, and this was in sharp contrast to Unload trial. Actually, this was the reason why this study was stopped after 186 patients. Let me just open a parenthesis and say that worsening renal function in heart failure, in acute heart failure, has a specific meaning. We know that renal dysfunction is bad, but in heart failure patients, it might have a different meaning if it is associated with decongestion. Just a couple of months ago in Brussels, I was presenting the studies that showed actually if you have a worsening renal function, when I am treating you for acute heart failure, you probably have better outcomes. And the opposite, If you show improvement in renal function, where I'm treating you for acute heart failure, this is associated with poor outcomes. That is surprising, but that has some pathophysiologic meaning to it. Well, in terms of mortality, they followed the patients for 2 months, and there were no differences. When we look at the unload and Karis, unload was done customized flexible ultrafiltration therapy with suboptimal unprotocolized medical therapy. Ultrafiltration 1. In Karis heart failure, we did the other way. We did suboptimal ultrafiltration, 200 milliliter per hour for every patient, no matter what, versus customized therapy, medical therapy. What did we find? Medical therapy was superior. So if you think about it, we need a fair comparison to just compare optimal therapy with ultrafiltration versus optimal therapy with diuretics. Here comes Avoid Heart Failure trial, was published last year. So here you see an A before loop diuretics and A before ultrafiltration. This is adjusted loop diuretics versus adjusted ultrafiltration. This time we learned the lesson. We should do it optimal therapy. And we went for acute heart failure patients, 224 patients. Unfortunately, this study was supposed to recruit 800 patients, but it is probably unrealistic because it is an invasive intervention study. Anyways, after 224 patients, the sponsor stopped the trial. So we take with a grain of salt the results that we see because it might not be powered. This slide is not meant to be read. This slide is meant to say that we have a great protocol for our medical therapy. We knew what we should do for each step of the way. The same for ultrafiltration. We had a great protocol for that. This is the main finding of the study. Loop diuretics versus ultrafiltration. It seems that after the first week, time to heart failure event was better in ultrafiltration than the loop diuretics. Having said that, there was a trend only because it was statistically insignificant. We wonder if there were adequate number of patients, we would see something significant. Just similar to unload trial, the secondary endpoints turned out to be in favor of ultrafiltration, such as the number of days rehospitalized for heart failure, for example. And again, they looked at the renal function 9 time points after that index hospitalization up to 3 months later, and they didn't see any difference between the two groups. So ultrafiltration was not associated with worsening renal function. Well, I talked about the benefits or proposed benefits of ultrafiltration. It wouldn't be a balanced discussion if we do not talk about the proposed disadvantages. There are a number of them. Need for anticoagulation or cost have been discussed quite a bit in the literature. One thing that I did last year in an editorial, I just compared the sodium extraction between ultrafiltration and diuretics based on a study that was done by Dr. Chang at the University of Cincinnati, and I applied them to Karis heart failure trial results that we had. I found that after 4 days, the whole difference between the two arms in terms of sodium extraction is less than 100 millimole. So it doesn't seem that important to explain the sustainability of beneficial effects that we saw after 3 months. The ultrafiltration group were still doing better in terms of hospitalization. Well, this field might be a good area to use meta-analysis with admittedly all the inherent limitations. Because we have very small studies, pretty much the same patient population and the outcomes. So if we pull the data together, we might find something reasonable. We looked at 7 studies, including more than 700 patients. These are the studies. They're mostly done in the US. 2 of them are in Italy. That's Corporeal trial from Giancarlo Morenzi in Milan. One limitation of the ultrafiltration studies is the follow-up. The follow-up periods are very short. Here is the follow-up. You see that the longest one is 12 months, most of them 1 to 3 months. These are the different endpoints of interest that we looked at. In terms of weight change, as you see, ultrafiltration is associated with better reduction in weight. And you remember, we are looking at weight change and fluid removal just separately because, as you know, in heart failure, it has been shown that they are not correlated. So if you want to look at congestion and as surrogates of congestion, you need to have both. So for fluid removal, again, you see that ultrafiltration is doing better than diuretics. In terms of change in creatinine, it seems that both groups have similar results. In terms of rehospitalization for heart failure, there is a trend for favoring ultrafiltration. It seems that ultrafiltration is associated with better outcomes in terms of not bringing the patients back to the hospital. As you saw, it has the highest readmission rate, heart failures, and the major financial burden is the inpatient care. So it might have some financial implications. In terms of mortality, it doesn't seem that any of the two modalities would improve the outcomes or worsen it. Adverse events, the ones that we saw, it was very heterogeneous. It seemed that they do not favor any modality. So if I want to summarize my whole talk in one slide, this would be the summary. It seems that mechanical extraction of fluid versus diuretics, it gives us better weight loss, better fluid removal, probably lower heart failure rehospitalization, so it brings us better decongestion. And it doesn't come at the cost of impact on renal function, mortality, or adverse events. If I want to give some practical recommendations, this would be based on the trials that I showed you. It seems that if we want to do ultrafiltration, it is better to do it early versus late. You saw that in Karis heart failure, when we were waiting for renal dysfunction to happen, the results were not great. We need to customize the protocols, and we need to have objective monitoring of decongestion, such as BIVA that we just heard about. So when I talk about customization of the protocol, I'm looking, for example, this is the avoid heart failure, just an example. When you see they had a very detailed protocol how to start ultrafiltration for a patient based on the clinical characteristics. Let me finish by saying that because of the results that are not necessarily the same from different trials, the recommendations from the societies are also very vague. Some of them might even be in contrast to the findings of the studies. For example, here you see from Heart Failure Society of America, they say when congestion fails to improve in response to diuretics, ultrafiltration might be considered. This is actually what Karis heart failure trial tried, and it didn't improve any of the outcomes. Thank you very much for your attention.